Welcome, everyone, and thank you for joining our University of California system-wide grand rounds. Our topic today is the impact of dentistry in California. I'm Deena McRae, the Associate Vice President for Academic Health Sciences at the UC Office of the President. We're happy to host a series of presentations to help our UC Health community and colleagues remain up to date on hot topics and issues that impact our profession and the communities which we serve. This Grand Rounds series also serves as an opportunity to showcase some of the extraordinary, innovative work that's occurring across our UC health system, work that is inspiring others across the nation and around the world. And I want to take some time to thank everyone who helped create and support these UC system-wide Grand Rounds, especially Lisa Badavinas. We're pleased to offer these educational sessions to our UC faculty, staff, residents, and students. It's a CME and dentistry continuing education event. After this session, you can provide feedback and get continuing education units for participation. You'll receive an automated email tomorrow to claim your continuing education units if you wish. Also, time will be allotted for answering questions verbally at the end. Please feel free to use the Q&A feature for entering questions throughout, and we'll answer as many questions as possible at the end of the presentations. The speakers do not have any disclosures. I am honored to be here today to showcase three expert leaders from our UC Schools of Dentistry here to discuss the role of dentistry in our overall health, the impact on our communities, and what UC is doing in this space. First, we will hear from Dr. Jennifer Perkins, the Associate Dean of Education and Health Science Clinical Professor in the Department of Oral and Maxillofacial Surgery at UCSF School of Dentistry. Dr. Perkins holds a BS in Biochemistry and Cell Biology from UCSD, a DDS from UCLA School of Dentistry, and an MD from UC Davis, and a certificate in Oral Maxillofacial Surgery from UCSF. She is clearly committed to the UC system. Thank you, Dr. Perkins. She was hired as faculty at UCSF upon completion of her residency in 2013. Dr. Perkins maintains a clinical practice that is devoted to providing oral surgery care to patients who are pre and post radiation due to head and neck cancer. As Associate Dean, she manages all educational aspects of the DDS program and also provides oversight of the dental postgraduate residency programs, continuing dental education, and other broad educational initiatives for the School of Dentistry at UCSF. Next, we'll hear from Dr. Yvonne Hernandez-Kapila. Dr. Hernandez-Kapila is a professor of dentistry at UCLA in the sections of biosystems and function and periodontics. And she is the Felix and Mildred Endowed Chair at UCLA School of Dentistry. She is also an Associate Dean of Research. She received her DDS, periodontology residency training, PhD in oral biology, and postdoctoral fellowship from UCSF. Dr. Hernandez-Kapila is a clinician scientist and academic and research leader with over 30 years of research, teaching, mentoring, clinical, and administrative experience. She started her academic career at UCSF, and after 17 years as a member of the UCSF community, she was recruited to the University of Michigan School of Dentistry, where she rose to the academic ranks to full professor and became the inaugural director of global health initiatives at the school. UCSF recruited Dr. Hernandez-Kapila in 2016, and she became the chair of periodontology and R. Earl Robinson Distinguished Professor of Periodontology. In 2022, she was recruited to UCLA School of Dentistry, where she has a focus on administration as Associate Dean of Research on clinical teaching, patient care, and service. Finally, we'll hear from Dr. Jean Marie Starr, an Assistant Professor of Clinical Orofacial Sciences in the Division of Pediatric Dentistry at UCSF School of Dentistry. Dr. Starr is a pediatric dentist dedicated to improving oral health for children and adolescents, with a focus on making dental visits positive, preventive, and accessible. She is particularly passionate about caring for underserved populations, including children with complex medical conditions and special healthcare needs. Dr. Starr earned her BDS from the UCSF School of Dentistry, where she also completed her specialty training in pediatric dentistry. She holds a master's in public health from the Harvard T.H. Chan School of Public Health with an emphasis on social determinants of health. Her research focuses on minimally invasive approaches to dental care and innovative models to increase access, especially for children at high risk for dental disease or who face barriers to traditional care. At UCSF, she is also expanding pediatric dental residency training and public health, collaborating with behavioral health teams to improve dental care for children with autism, and mentoring students and residents in public health and clinical and translational research. We are honored to have these prestigious leaders with us today. I will now turn it over to Dr. Perkins to discuss dental education and improving access to oral health care.
Thank you, Dr. McRae. Thank you so much for having us here. I'm thrilled to share with you a few of the initiatives that we have going on here at UCSF School of Dentistry, where we're using the training of our predoctoral dental students to help improve access to oral health care for the state of California. So to set the stage, California has numerous oral health care deserts, which are consistent with the medical health care deserts that many of us are familiar with. About 20% of California communities have a shortage of dentists. 2/3 of the dental shortage areas here in California are rural, and you can see this on the map of California in this slide. The paler green areas and the darker green areas are those that have a critical shortage of dentists to serve the population of those particular counties. You can also see that dentists are heavily represented in some of our urban areas, including the Bay Area and Orange County, but most of the state doesn't have the access to the dental providers that they need. And interestingly, despite various efforts and attention to this, these findings have been consistent for more than 20 years without real improvement. So how does UCSF fit into this? We're an institution that is clearly urban, has been treating the urban underserved population here in San Francisco since our inception. Something that contributes significantly to the overall oral health care shortages in California beyond rural location is the fact that only 10% of dentists treat Medicaid patients in California. So our clinics here at UCSF, by contrast, are seeing about 55% Medicaid patients. So we are filling a pretty significant gap in access to care that would otherwise exist for patients local to us who have Medicaid dental benefits. We're also the main referral destination for higher complexity oral health care needs for both Medicaid patients and for other underserved populations. UCSF's predoctoral clinic, which is where all of our student dentists train. I think we're back one slide. Thanks. This predoctoral clinic is a very high volume center for Medicaid dentistry services. We have more than 160 dental students working in this giant clinic, seeing patients every week, which is how we treat our local community. We also have some longstanding efforts within the School of Dentistry here in San Francisco that aim to care for specific underserved populations. Dr. Starr will talk about one. Another that we're very proud of is the Community Dental Clinic, which has been in existence here for more than 30 years at UCSF, offering dental care primarily to the unhoused population of San Francisco. So it's an after-hours night clinic run by students, supported by faculty, that's provided millions of dollars of pro bono dental care to patients who otherwise would have no access. So we very much view it as part of our mission to do everything we can to make sure that the citizens of California have access to the oral health care that they need and deserve. One of the ways that we're doing this, one of the programs I'm here to talk to you about, is our community-based clinical education program, which we casually call our externship program. This is a program that's been longstanding in the School of Dentistry, where we send each of our DDS students out to spend 6 weeks at a community partner site. The students work at these community partner sites under the direct supervision of a licensed dentist. We currently have 23 separate partner sites, which are predominantly federally qualified health centers and community clinics that are treating truly underserved populations. They're spread out throughout the state of California, including some tribal health clinics in very remote areas. And while we have a number of sites that are local to us in the Bay Area, we have an even larger number of these that are intentionally in rural areas. As part of this program, our students have a supporting coursework that focuses on dental public health, social determinants of health, and some of the unique considerations for providing care to specific underserved populations. And our goal is just to prepare them for having an amazing experience when they go out into these community partner sites. So I would say this program has been very successful bidirectionally, and has had a lot of positive impact. Our learners definitely benefit from their participation in the externship program, because when they go out, they are effectively acting as the dentist. They are very closely supervised, but they're working in a much more real life pace. Relative to their speed and the number of patients that they can see in a day. So it is a real world training environment, which would be very hard to replicate within the walls of a training clinic like ours here at UCSF. At the sites, the students also get to work with trained dental assistants, which is new to them, and they learn how to incorporate the support of dental assistants into their practice of dentistry. They are much more competitive for employment as a result of the work that they've done with our community partners and the skills that they've acquired. And they get exposure to different practice settings. Not every dental student would consider employment in a community clinic without this exposure. Many of our students, pursue the full gamut of possible employment outcomes, including specialty residencies or private practice. Some stay local to us in San Francisco. But sending them to these rural sites can have career-changing impact on their future practice plans, including what they do immediately after graduation. And we're always thrilled when a graduating student chooses to work at that same community partner site where they served as an extern right after graduation, which does luckily happen. Of our partner sites, of the 23 sites, almost 40% of the directors of those dental clinics are UCSF School of Dentistry graduates, and an even greater percentage of the general faculty at the sites are also UCSF School of Dentistry graduates, which goes to show that there's a long-term benefit to placing our students at these sites. There are also, pretty obvious benefits, I think, to the partner sites. Our dental students provide a workforce that would not otherwise exist in these clinics, which really increases the capacity in very busy clinical settings. It reduces delays in getting patients the appointments that they need when you have an additional dentist seeing 6 or 8 or more patients every day. There's also the element of interprofessional practice. Most of these sites have co-located medical or mental health or other healthcare services, and our learners kind of engage with these teams and can offer their specific oral health knowledge to that interprofessional team. We, sometimes get an evaluation back that says this was the best student. We would love to have this student come and work for us after graduation. And we have had that very thing happen. So that is certainly the recruitment element is a benefit to the partner site. Finally, all of our faculty who supervise our students end up receiving volunteer clinical faculty appointments, which is good for their career development. And of course, they're helping our profession tremendously by training our next generation. So what have we been doing recently to improve this longstanding program? For the past year, we've added an additional 4 weeks of externship to the pre-existing 6 weeks, bringing us to a total of 10 weeks. We've also started sending our students out for the first 4 of those weeks at the very end of their 3rd year of dental school instead of waiting until the 4th year. To make that happen, we had a pretty significant shift in our whole curriculum to allow our students to enter clinic earlier. We know that they need to be with us for a year at least of continuous training and assessment to make sure that they're practice ready for deployment to our community partner sites. So we now have them entering clinic in the 2nd year, which gives them overall more clinical exposure and readiness. We really think they should be going out in their 3rd year because this is when dental students are typically making decisions about their career trajectory. By the 4th year, they know what they're going to do next year, and it's a value to send them out to work in these community partner sites as they're choosing where they might want to see themselves working after graduation. We're also adding, of course, an additional 40% of clinical work for the sites by adding those extra 4 weeks. And finally, we're changing how we're assigning students to each of these sites. We always want to be very respectful of student preferences, but we have seen that many students need some encouragement to consider going to a rural or remote site. We've started assigning students to at least one rural or remote site, and have seen that students who went out for that first rural externship are much more likely to volunteer to go to a similarly rural site for the second one. So it goes to show that that exposure is critical. We're also onboarding new partner sites all the time. It is our continuous effort to find and recruit these excellent sites to help train our students. So, the final initiative that I'll talk about, which we're very proud of, is our DDS Aspire program. So, DDS Aspire stands for Doctor of Dental Surgery, Advocacy, Science, Public Interest, and Research. This is the brainchild of our dean, Dr. Michael Reddy, who's created this program in dentistry that's modeled on the UC Prime programs, which focus on addressing healthcare shortages in the medical healthcare deserts of California. And we are really thrilled that this DDS Aspire program has recently been given initial funding by the state of California. So we're now working at full tilt to launch the program next year. The idea behind this is that we're going to train and prepare our students to provide high quality oral health care to underserved communities throughout California. We'll be integrating the learners in this program into our standard 4-year DDS curriculum with the option of doing an additional master's degree afterwards. And the way that it will work is that we're going to be recruiting dental students from underserved and critical access areas across California. And in addition to our existing robust standard curriculum, we're going to be providing them with enhanced leadership, public health, advocacy, and research training that will position them to be contributors when they graduate and move back into the communities to practice dentistry. We're going to also expand elements of the community-based externship program that I've just described, which all of our students do. And the intention is that the DDS Aspire program's graduates will not only be prepared to go out and provide excellent oral health care, but also to advocate for the resources that are required to address oral health disparities and health inequities that exist in the communities that they're going to serve. And we're looking forward to launching this next year. With that, thank you very much. I will now turn us over to Dr. Hernandez-Kapila.
Thank you, Dr. Perkins. Thank you, everyone, for the invitation to share some information with you today about dentistry and oral health. All right, so first of all, I'm going to begin by setting the stage about oral diseases, which are the most common non-communicable diseases in the world. They affect about 3.5 million people all over the world, about half of the world's population. You can see in the graphic here the comparison of other major non-communicable diseases in comparison to oral diseases. Oral diseases have a very significant impact on the world. Here are some key facts to keep in mind about the global oral health burden of disease. Oral diseases are largely preventable, although they pose a major health burden. They affect people throughout their lifetime. They cause pain, discomfort, disfigurement, and even death, affecting about 3.5 million people all over the world. Some of the major oral diseases include untreated tooth decay or cavities, which are the most common disease. Prevention and treatment are expensive, and usually it's not included as part of universal health coverage. Assessing data from 194 countries, the annual costs globally are around $710 billion. Modifiable risk factors include sugar consumption, tobacco use, alcohol use, poor hygiene, and underlying social and commercial determinants. Some of the health care implications are the following. The Surgeon General's report in 2000 put it very well by saying that oral diseases are a silent epidemic, and oral health is an essential part of general health and well-being. Oral diseases are highly prevalent, as I mentioned before, and they're associated with significant morbidity. Dental cavities are the most prevalent worldwide. Severe periodontitis or periodontal disease, which is a disease of the gums, affects up to 50% of adult populations. Oral cancer is the 8th most common cancer worldwide, and half of HIV-positive patients have oral, fungal, bacterial, or viral infections. Just to point out some trends that are important and projected to continue, let's focus on tooth decay, periodontal disease, and oral cancer. So these trends are impacted by the global aging population in our country and legislation to remove fluoridation from municipal water sources that will also have an impact, as well as the shortage of providers and educators entering and training academics, which Dr. Perkins touched on in her presentation. Let's look at the graphic shown here on the graph at the left. And what you'll notice is that there's this big inflection point that shows that the number of aged individuals surpassed the young individuals in 2018. And that's a very important shift to keep in mind. The population is continuously aging as the young population is declining. The fact that there's a movement towards banning fluoridation in multiple states in the US will also have a significant implications for oral cavities and oral diseases. This figure highlights the health professional shortages in areas around the US. The color scheme here shows that the most impacted areas are the darker colors, where there are fewer providers, and the majority of our country lacks access to sufficient dental care. Let's focus on tooth decay and overall health. Tooth decay impacts physical health, social interactions, and psychological well-being. Physical health is impacted just by the presence of tooth decay. This can lead to nutritional deficiencies, especially in children, causing malnutrition and stunting, and can also lead to systemic inflammation. From the social and psychological health perspective, there is a reduced quality of life, and it can impact school and work attendance. What about oral cancer? Again, oral cancer is one of the leading causes of death worldwide. Risk factors include genetic mutations, tobacco, alcohol use, HPV infection, and chronic bacterial infections. Oral cancer is associated with alcohol and tobacco use and infection with high-risk HPV species. HPV 16, for example, is one of the main culprits that are currently driving the dramatic rise in oral cancers. Anatomic location often limits complete surgical resection, thereby leading to incurable disease. Let's look at some of the main oral cancer risk factors in the global setting. Tobacco use is highest in Southeast Asia and Europe. Alcohol use is highest in Europe. And in the graphic here on the left, the incidence of oral cancer attributable to HVP is much higher in males than in females in certain parts of the globe. The graphic on the right shows that there are gaps in gender-neutral vaccination globally. So the big takeaway here is that the incidence of HPV-positive oral cancers is growing across the globe, and this is an important trend for HPV-positive cancers. Now let's talk about oral cancer and overall health. What are the implications here? First, physical function. We know that oral cancer treatment changes taste, smell, appetite, speech, breathing, swallowing, leading to potential malnutrition and weight loss, and of course, facial disfigurement from surgical resection. Well, what are the dental problems? There's radiation xerostomia or dry mouth, there's dental caries, and there's very painful ulcers or mucositis. And for patients, their quality of life is impacted negatively. It affects physical and emotional and social well-being. In individuals, there's an increased risk for other diseases besides these, as related to poor oral health, which is linked to diabetes and dementia. And the survival rates vary depending on the stage and location. Early detection and treatment are critical. I'm going to shift gears here now and talk about a very important connection between oral health and systemic health, and the fact that these are inextricably linked. We take as an example periodontal disease. In this diagram shown here with the tooth in the middle, individuals that have gum disease are negatively impacted because the disease has been associated with many chronic diseases and conditions. For instance, we've known for a very long time that periodontal disease is bidirectionally linked to diabetes, so both can impact the other. Treatment for one will impact the other. Another example is adverse pregnancy outcomes, and more recently, there has been emerging evidence on the connection between periodontal disease and Alzheimer's disease, and I will show some highlights in the coming slides on these connections. Periodontal disease and diabetes. We know that there is an increased risk and severity with higher prevalence of periodontal disease for individuals that have diabetes, especially when these conditions are not well controlled. As I mentioned, there's a bidirectional relationship and a dose dependence. The severity of diabetes depends on glycemic control, and this contributes to tooth loss. Mechanisms include chronic inflammation and microbial imbalances or dysbiosis. So that's what the cartoon on the right here is showing. A microbial dysbiosis simply means that the bugs that live in our cavity change in their composition. They change from a composition that is healthy to one that is not, and that promotes inflammation. What about periodontal disease and cancers? Let's take the example of colon cancer. So individuals with periodontal disease have a higher risk of developing colorectal cancer. And again, common mechanisms driving this association include chronic inflammation and specific oral bacteria such as Fusobacterium nucleatum. This is found both in the mouth and in the colon and gut microbiome. And among all the bugs that live in the gut, there is a disruption that leads to dysbiosis or an imbalance. This leads to an increased risk of precancerous lesions such as polyps in the colon. So this calls for early screening for individuals that have gum disease to screen for polyps in the GI tract. Another example that is emerging is the connection between periodontal disease and Alzheimer's disease or dementia. Individuals with periodontal disease have presented with an increased risk for Alzheimer's disease, and bacteria that are associated with gum disease may contribute to Alzheimer's disease progression. This leads to neuroinflammation or inflammation in the brain. Potential mechanisms again include direct bacterial invasion or inflammation that's induced by the bacteria that live in the gums that then find their way into the brain, and this leads to the formation of the amyloid plaques in the brain that contribute to Alzheimer's disease. The graphic on the right shows that these two main mechanisms that have been highlighted in literature, which can be described as a microbial involvement mechanism and an inflammatory cascade mechanism. These are the two predominant mechanisms that have been reported to be part of this axis of disease. So there's emerging evidence about a connection between the oral, the gut, and the brain. There is a novel paradigm connecting the axis of disease and the potential use of antimicrobial-based therapeutics to mitigate the microbes that are known to potentially be this mechanistic cause through the potential pathways of leaky gums and leaky gut and leaky brain. This axis of disease is very important, connecting these various components of the body, and is a potential new avenue for intervention and for treatment. This takes us now to the summary and future directions. We need to increase awareness and education about oral health. Primordial prevention is key. Early detection and intervention are also critical to improve health outcomes. And increasing training, as was mentioned by my colleague, Dr. Perkins, is very important to ensure that we have adequate providers across the state, across the country, and across the world. There is a need to continue for continued omics, or large comprehensive studies of biological systems, and the use of artificial intelligence to guide us to be able to predict risk. We have some exciting future directions, such as the UCLA initiative, where we were recently funded and have started to characterize the human virome through the center to examine the virome across all of these body axes to discover potential connections between the oral health and systemic health. And now I will pass this on along to Dr. Starr. Thank you.
Thank you all for inviting me to speak this afternoon, and thank you to Dr. Perkins and Dr. Hernandez-Kapila for getting us started. We've had the opportunity to hear from them and explore some important topics like advances and innovations in dental education and the global burden of oral disease and its connection to overall and systemic health. I'm excited to share with you a topic that I'm particularly passionate about: pediatric dental care for children with special healthcare needs, and how we're working to improve access and outcomes in oral health for this particular population. Pediatric oral health care is exceptionally important. We know that having cavities in our baby teeth is the #1 predictor of having cavities in our adult teeth. So helping kids develop good oral habits early on is very important. But despite knowing this and knowing the long-lasting impact of cavities in children, dental caries is still extremely common. In fact, cavities is the most common chronic disease in childhood, more common than a child having something like asthma. And when we think about children with special healthcare needs, the barriers to achieving oral health are even greater. Some children have special diets or sensitivities that affect the way they eat and how often they eat, which puts them at increased risk for cavities. Things like brushing and flossing can be difficult, especially for children with physical differences or motor challenges. And families may struggle to find a dentist who feels comfortable treating their child, or even one who is just willing to see them. These are the realities we have to face and understand if we want to provide oral health care that truly meets families with children of special health care needs where they are. As many of you have likely heard, the number of children being diagnosed with autism has been increasing in recent years. The rise is likely due to better screening tools and improved diagnostic methods, which allows us to identify children earlier and thus provide the support they need. And that's a good thing. But as we think about this growing population of children being diagnosed with autism, we also have to think about their oral health. Children with autism can have increased risk of getting cavities. Many children with autism have specific or restricted diets that contribute to tooth decay. Some experience sensory challenges that makes brushing and flossing extremely difficult. And in some severe cases, children may not tolerate someone even touching their face or looking in their mouth for a brief dental exam. As the healthcare system has grown in understanding how to support children with neurodevelopmental disorders such as autism, many kids now receive great, collaborative, individualized care that helps them succeed despite their autism diagnosis. Supports can include a lot of things. This can include individualized case management from our regional centers across California, individualized education plans in their schools, speech, occupational, and feeding therapy. And many children with autism also see their physician or primary care provider who is experienced in meeting their specific developmental and behavioral needs. But what about dentistry and oral health? If we recognize the importance of tailoring all these other aspects of care to children with autism, it's important that we also think about tailoring oral health care for children with autism and neurodevelopmental disorders. Can we expect these children to just be able to adapt automatically to the dental system that we have today? I don't think we can, and we shouldn't. And that's exactly why we try to think differently about how we can introduce and deliver dental care that is designed for children, specifically for those with special health care needs. Let's all take a brief moment and think about the dental setting. I am assuming that most people here today have been to the dentist. And even for an adult or a child without a special healthcare need, a dental visit can be overwhelming. There are bright lights, unfamiliar smells, the sounds of the dental tools, and just the foreign feeling of someone working in your mouth. It is a lot to take in. Now try and imagine that experience through the lens of a child with autism. For many of these children, the dental environment can trigger sensory overload. There's so many new sights, the things that smell weird, the sounds, it can be too much for them to handle. And while not every child with autism needs specialized, unique dental care approach for them, many do require preparation and support in order to feel safe and comfortable in a dental clinic. At UCSF, we recognize that providing dental care to children with autism requires more than just our traditional clinical skill. It requires an environment that's built around trust, flexibility, and collaboration. And for this reason, we have developed the UCSF Division of Pediatric Dentistry Autism Program. This program is specifically designed to support families and children with autism through a more thoughtful and inclusive dental experience. The goal of our program is threefold. The first is that we really want families to feel welcome and supported. Many parents come to us having faced rejections or challenges in other dental clinics. And we aim to offer a space where they feel welcome and that they have a knowledgeable provider for their child. Secondly, we built an interdisciplinary clinic model where we work closely with behavioral health teams and other providers. That way, we're not just addressing oral health, but we're addressing the whole child. And finally, and importantly, this program is also about building for the future of our healthcare workforce. We train dental students and residents to become competent and compassionate providers for children with special healthcare needs. We know that trainees who go through our program will go on to be dental providers all over California and beyond. And they can bring the skills that they develop in this program to far-reaching communities. What specifically makes this program unique is the interdisciplinary team behind it. At our core, we have UCSF Pediatric Dentistry, where we have our pediatric dental residents and faculty. We also work with an amazing board-certified behavioral analyst who helps us think through behavioral supports and communication strategies that are individually tailored for each child. We also collaborate closely with the UCSF Center for Autism Spectrum and Neurodevelopmental Disorders, bringing together expertise in psychology, social work, psychiatry, and developmental primary care. This connection and collaboration allows us to approach oral health, not in isolation, but as part of the child's whole developmental journey. The core belief of this program is that going to the dentist is a life skill. And like any other skill, it needs to be taught and practiced and supported over time. By the time a child with autism comes to our program, many families tell us that they've already experienced a lot of challenges related to dental care. Things like appointments ending early, or providers who are unsure how to address their child, or even people who have told these families that the only way that their child can receive dental care is with restraint or sedation. In our program, our aims and goals are different. Our goal is to help every child build comfort and confidence in the dental setting, to tolerate and participate in routine and preventive dental care, both in our clinic, and also to develop and support the skills to have good oral hygiene practices completed at home comfortably. So how does our program work? Well, first, children are referred to our program from all over. Children are referred to us internally from UCSF School of Dentistry. We get referrals from psychiatry, from primary care providers, and community dental providers. And actually, we get a lot of children sent to our program from word of mouth. Parents in this program are sharing with other parents of children with autism that they can come to UCSF School of Dentistry for autism-informed dental care. After the child is referred to our clinic, the first thing we do is a telehealth consult with our patients. This gives us time to really talk to the parents and understand what is going on. What is their child's unique needs? What are their communication styles? What are their past dental experiences? What are their unique sensitivities? And how can we best support their child when they come to the dental clinic? And we gather all of this information before they even step foot at UCSF School of Dentistry. After this initial consult, we practice systematic desensitization in our autism dental clinic. Systematic desensitization involves more frequent, shorter dental visits, and not necessarily all of the parts of the traditional dental visit at once. In each visit, we have a single goal that we're trying to achieve, and we work towards that with our interdisciplinary team and with behavioral supports. We have broken down a routine dental visit into something called a task analysis, which is a concept from behavioral health, which takes a complex multi-step process and breaks it down into smaller incremental steps. For example, one step in our task analysis is getting the child to sit comfortably in the dental chair. And sometimes that might be our only goal for a visit, because sitting comfortably in a dental chair is a skill that not all children might innately have. And we work through achieving all the steps of a routine dental visit over time. And I will say, the progress is not always linear, but we have been able to successfully work with children to help them go through the different steps of the dental visit without being overwhelmed. And it's one of the great successes of our program. In the program, we also use a variety of clinical supports. These supports are designed to meet each child where they are. This means offering things like breaks during dental visits, sensory toys that can help to relieve stress or anxiety or act as a distraction. We use timers to prepare for transitions so children know how long do I have to sit in the dental chair? How long is this going to take? Helping them to see visually how much time is going to be expected to them. And we use things like weighted blankets on top of children who are sitting comfortably in the dental chair to help support sensory regulation. We also do some fairly extensive preparation for these visits as well. Depending on each child's need, we might create a social story to show them what to expect in the dental visit that day. And we also have a pre-visit walkthrough video, which shows a child entering our dental clinic and going through every step of the visit. Many children with autism benefit from watching a video like this before coming to the clinic, so they can see what is going to be expected of them and help to have some anxiety relief when they arrive. When we think about evaluating the outcomes of this program, I like to focus on three things. The clinical perspective, is this working for my outcomes, for my clinical needs? From the patient experience, are the parents and the kids liking this? Is it being well received? And importantly, the trainee impact. One of the long-lasting impacts of this program, I think, is going to be the training of providers to be able to provide this autism-informed care outside of the walls of UCSF. So talking about the clinical perspective, doing a retrospective study of our program, we did find that there was statistically significant positive relationship between the number of desensitization visits a child has completed and that child's ability to complete a routine dental visit, including an exam, cleaning, and preventive care. I will tell you anecdotally, we work with kids who can't even enter our dental clinic without having a meltdown. And after working with them over several months to a year, we're able to help them build the skills and confidence and comfort to come into the dental clinic, sit in the dental chair, lay down, and allow us to do an exam and cleaning and fluoride in ways that probably the parents thought were never achievable before. I also really like to talk to the parents and understand the family perspective. These families have a lot of challenges in obtaining care, and I want to be sure that we're meeting their needs. Recently, we completed a qualitative study to understand the parental perspectives of participating in an autism program like this. And I will tell you, they've described it as incredibly impactful. One parent said he used to hate going to the dentist, and he loves to go to the dentist now because you guys don't really push him, and it built a trust. And I think that that is one thing that our program is really doing is it's giving children who might be nonverbal or don't understand always entirely what's going on, that they can trust healthcare providers, they can trust dentists, and we can do this for them comfortably. Lastly, from an educational standpoint, we have been training pediatric dental residents in this program for the past 5 years. And I know we are shaping a generation of providers that will be prepared to care for those with special healthcare needs in their future careers. In conclusion, the core thesis of our work is that all children, regardless of their special healthcare needs, deserve dental care that supports and accommodates them individually. Through collaboration, we're working to shift the dental care paradigm, making specialized care a standard for those with special healthcare needs. And I believe with the right preparation, the right environment, and the right team, every child can gain the skills needed to have a lifetime of excellent oral health. I thank you for your time and your attention, and I will now turn us over to Dr. McRae for questions.
Thank you to all of our exceptional presenters today. We've been collecting questions as they appear in the Q&A feature. The first question may be directed towards Dr. Perkins. And the question is, can you discuss how community-based dental education programs may be further structured to both enhance student clinical competencies and address oral health disparities in underserved populations? What do we need to make that happen?
It's a great question. And I could go on. There's a lot to say about this. I think the The first thing is to recognize that we are indebted to our community partners for taking our students and giving them these amazing training experiences. And it's important to sort of um, meet them where they're at and understand what their, specific clinical setting needs are. I would say, don't have a desire to outsource education assessment and like a lot of the sort of core functions of training dentists entirely to the outside community. But the first step in getting more probably consistent or structured training is to really understand what the sites need from our learners. The other thing is it's actually kind of hard to get in the door, but once we send our fabulous students out and they demonstrate what they're capable of doing, all things become possible. I think there would definitely be a need for more onboarding and more training, kind of specific to education, to pedagogy, to clinical education and training if we were going to create more structured experiences. And one thing we are doing already is really using big data to determine what is happening at each site. So we have students using Smartsheet online tool. They do it from their phone, documenting, everything they're doing during a very busy clinic day. And from that big data set, we're pulling out trends for each site. So we now have sort of a signature for each site and we know what they do. And one of the ways to create sort of a, I guess, more structured or more uniform experience for learners is to diversify where they spend their time. So we've already started doing that. If we go to a site that does a lot of a specific type of dentistry, pediatric dentistry, we will then send that same learner out to an adult heavy geriatric focused clinic to make sure that they have a diverse and equitable among the whole cohort of students experience.
That's fantastic. I really appreciate that data-driven approach and the intentionality of making sure the students have that diversity of clinical experience. The next question may be directed towards Dr. Hernandez-Kapila. So the question is, how does the concept of leaky gums, where inflamed periodontal tissues allow oral bacteria to enter the bloodstream, help explain the link between periodontal disease and systemic conditions like as cardiovascular disease, diabetes, or adverse pregnancy outcomes? Is there a common mechanism?
Mhm. Thank you for that great question. Yes, so it all really begins with this, the leaky gums that we talked about, and this concept that when you have gingivitis or inflammation of the gums and or periodontal disease, periodontitis, which is sort of the next step where you have bone loss, not just inflammation of the gums. And all of these really are characterized by inflammation and more blood vessels where you have inflammation. And what happens is that then when you have this break in barriers, if you will, that there's this gum barrier is broken down, and this allows bacteria and the toxins that they release to enter the body's circulation. And then these components then basically through the highway of the circulatory system find their way throughout the body, seeding all of these sites, whether it's the brain or the reproductive organs, all throughout the body. And in fact, some of these bacteria have been found in atherosclerotic plaques. And so it's believed that through this great highway of the circulatory system, that these bacteria, these microbes, and the stuff that they secrete find their way to different body sites and can initiate or potentiate disease.
Thank you very much. I had this visual image in my mind as you were describing all that. Thank you. The last question is going to be for Dr. Starr. Can the interprofessional approach for autism be expanded to other teams in the community to improve the oral health experience and outcomes for patients with autism spectrum disorder?
Thank you. This is I think, a really great question. Obviously, not all children with autism can come to UCSF for dental care. So I feel like this is something that we've been piloting and trialing, and I think importantly, also providing evidence and demonstration that it works. I can totally see this being expanded to a lot of other community-based sites. I recently met with the California Department of Developmental Services, who is actually really interested in expanding dental desensitization to their regional centers. And I think one of the great things is that you don't actually need a dentist to do this. A lot of the things that I do for desensitization can be done by a dental staff member, a hygienist, or an assistant, or even by a behavioral therapist on their own. So I do see that as this advances and we see more people practicing desensitization, I think it will be happening more in our community health settings. I think synergistically about this program and about the externship program and about our graduates going to work in community health centers, I can totally see some of our students who work closely and rotate through our autism program going to get a job at a community health center and saying, oh, I can see this kid with autism. I saw in this rotation that it happens. And so I hope going forward, this will be really broad in the community.
Thank you very much, Dr. Starr. It's great to see the impact that the graduates are having on our communities. Well, thank you very much to all of our speakers, and thank you very much to those who joined us today. As a reminder, tomorrow you're going to receive an automated email with instructions to provide feedback and plan continuing education units for participation. We did not get to all of the questions because there's just so much to discuss, and we appreciate your enthusiasm. You are welcome to connect directly with our presenters if you wish. And we will continue with this series, so keep an eye out for future webinars from UC Health. We aim to provide inclusive and equitable healthcare for all the communities we serve. Thanks again for joining and have a great day.